Hello, welcome to Stanford Care's monthly Community Health Talk series. My name is Dr. Justin Lee, and I'm a general cardiologist and also your moderator for tonight. I'm really pleased to bring to you this series of talks co-sponsored by Stanford Health Library and the Vincent V.C. Wu Foundation. I'm delighted to welcome Dr. Alan Yeung, who will be speaking on changing your heart valve through your leg. Is it real or fake news? Changing a worn-out heart valve, specifically the aortic valve, through the leg artery without bypass and avoiding the need to open up the chest may seem like a storyline from a science fiction. However, since 2008, we have been at the forefront of this cutting-edge technology at Stanford, having successfully performed over 2,600 of these procedures. In most of these cases, patients are able to return home the day after the procedure, resuming their normal activities with minimal restriction or discomfort. The incidence of worn-out heart valves typically rises in the 8th decade of life. Given the longevity of Asian women and men, this condition is relatively common in our community. Unfortunately, it is often overlooked or misunderstood, especially among the elderly. Both the patients and their family frequently believe it is too late or too risky to replace the valve. And there is also a cultural aversion among Asians towards undergoing open heart procedures. In this discussion, Dr. Alan Yeung will shed light on a specific condition known as aortic stenosis. The treatment, known as transcatheter aortic valve replacement, or TAVR, and its outcomes, particularly among the Asian population. Dr. Alan Yeung is a highly experienced, world-renowned interventional cardiologist. He is board-certified in interventional cardiology, cardiovascular diseases, and internal medicine. He completed his fellowship training in cardiology at Brigham and Women's Hospital in Boston. He is currently the Lee Carr-Singh Professor in Cardiology at Stanford University School of Medicine. He was also the past Chief of Cardiology at Stanford. Dr. Yeung provides care for a very wide range of cardiovascular disorders, such as coronary artery disease and different valvular heart disorders. He performs different procedures, including transcatheter aortic valve replacement, cardiac catheterization, and percutaneous coronary intervention, as well as balloon valvuloplasty. Dr. Yeung also conducted numerous research studies as a principal investigator and co-investigator. He has researched the placement of transcatheter aortic valve, the use of device to help with ventricular compliance, and the use of a vascular scaffold to treat coronary artery stenosis. He has received research grants both from the industry as well as from the NIH. Dr. Yeung also published his research findings in more than 300 peer-reviewed articles in high-impact journals such as JACC and Circulation. Please welcome Dr. Alan Yeung.
Really nice to have to share this evening with all of you to talk about a topic that is really dear to my heart, because I think in my career, this is probably one of the most important breakthrough technology that benefit to many of our patients. So Justin has introduced the topic already. It sounds like science fiction that you can change a big piece of heart valve through the leg. So I would hopefully share with you that indeed this is real, and we have been doing this at Stanford for the last close to 18 years. This is my conflict of interest. I've received grant support from some of the companies that make these graphs, but this is under a sort of a multi-center study, so it's hard for me to influence any of these results. So what is actually how the heart works? So I think it's important to understand that the heart valves, there are 4 of them, essentially allows the heart to receive blood from the body, which essentially go through this part of the what we call superior vena cava into the right atrium, the top part of the heart, and pumps it through into the lung. Because the blood returning from the body has been used up in terms of oxygen and nutrients, so we showed it here as blue. So once it gets to the lung through breathing will add oxygen to the blood and turn it red. So the blood is returned back to the left side of the heart through the left atrium, through a valve called mitral valve, and then through the aortic valve. The left ventricle is the main pumping chamber of the heart, which you see on TV. The heart is, pumping on a cartoon, for example. That's the ventricle that pumps the blood out. So the aortic valve allows blood to go through and go to the head, for example, and then down the aorta into the rest of the body, to kidneys, to liver, to your gut, to your legs. So really important for this valve to work, because if the valve is not working, blood is not coming out from the left ventricle. So what is aortic stenosis? So this valve, when it is healthy, is really thin. And when it's closed, it's completely closed, so with not leakage. So the blood would not come back from the aorta. And when it opens, it's pretty much completely open. So it's a big hole. So the heart has very little resistance to pump the blood through this valve into the aorta. However, if you have a diseased aortic valve, usually because of the buildup of calcium as you age, because this valve is open and close for 60 to 100 beats per minute for let's say 70 years, 80 years. And this valve essentially will build up calcium, thickened, and now it may not close completely, leaks a little bit, but more importantly, it cannot open. So when it cannot open, the hole where the blood has to come out becomes much smaller. So what happened is the left ventricle, this pumping chamber, has to work much harder to pump the blood through this small hole. So essentially it's asking you, for example, to breathe through a straw. You have to breathe much harder to push the air out. So the heart has been working gradually, more heavily over many years when this valve gets a little bit smaller. Obviously, it's a very serious condition that can weaken the heart, because the ventricle can eventually sort of say, well, I've been working too hard for too long, and therefore start to weaken and cannot pump blood anymore. Then you can develop a condition and get heart failure. So what are the causes and risk factors for the aortic stenosis? Not everyone gets it. So why would some people get it and some people don't? So the causes are obviously, as I said, calcium buildup, but also sometimes people were born with a valve that is not completely symmetric. For example, here you can see 3 leaflets, very equally distributed around a circle. But some people have actually valves that are slightly unequal in size. And some people will have valves that are stuck, meaning that instead of 3 leaflets, this, for example, here is fused, and therefore becomes what we call bicuspid valve, meaning there's only 2 leaflets functioning as if it's a fish mouth. The fish mouth is okay when you're young, when it's completely open, but the fish mouth, unfortunately, tends to narrow up faster because the blood flowing through it is not smooth, and therefore can trigger buildup of calcium even faster. So sometimes people have rheumatic fever as a child, or have radiation therapy through the chest, can cause damage to the valve and causes acceleration of the aortic stenosis. The risk factors are, when you get older, this condition is more common because just the wear and tear. High blood pressure can cause the valve to thicken as well, because more pressure is going through the valve. And also high cholesterol seems to do some damage to the valve as well. Smoking, and as I said before, you were born with a congenital valve that is 2 leaflets and not instead of 3. So the valve obviously takes time to get from a healthy 3 leaflets, become mildly thickened to moderately thickened and severely thickened, limiting the opening of the valve. Therefore, it's a progressive condition. And therefore, what can be done? Not a whole lot of things can be done medicine-wise. And there's been studies trying to show that lowering cholesterol can help, but it turns out if you study a large number of patients, cholesterol lowering doesn't really do very much for the aortic stenosis progression. So what is the sort of the magnitude, or how big is the problem is aortic stenosis? As you know, the number of people in the world that reaches age 65 and higher probably will double by 2050. So the whole global population, whether it's China, whether it's US, whether it is India and Japan, for example, worldwide is likely to grow from about 0.7 billion in 2020 to more than 1.5 billion in 2050. So 1.5 billion people that are basically age older than 65. And again, in America, the similarly large number of Americans will be 65 years and older. So this condition tends to occur in age 70, 65 to sort of 80. And you can see that with whether severe aortic stenosis or moderate aortic stenosis, meaning the narrowing is not severe yet, as you can see, can increase in age. You might say, well, how come greater than 80 doesn't increase further? Obviously, the part of the reason is that, the average sort of mean age in the US is probably, so life expectancy is about, low 80s. So therefore, obviously, some of the patients up here has, unfortunately, disease because of other conditions. So therefore, the incidence is definitely higher, especially, say, you can see the severe ones certainly is higher in the older age group. So this is a serious condition, meaning that if you have this problem and it's severe, and I'll explain that in a little bit, what does it mean by severe? You have about a 50% chance of living 2 years without aortic valve replacement. The reason is that the heart usually by this point is pretty tired, and therefore any sort of years of not replacing the valve will lead to the heart muscle further weakening, and further weakening leading to heart failure sometimes is irreversible, meaning the muscle is so tired that even if you change the valve, the heart muscle is not going to come back. It's not going to repair itself because essentially it had been working too hard and therefore getting some scarring and therefore difficult to go back to normal. So you may say, well, okay, you have this valve that is narrowing over time. So what do patients actually feel? Because this is one of the most important set of questions when patients come to see me about aortic stenosis, is that, do you have symptoms? Because obviously when you are older, we want to make sure that when we do a procedure, it will improve your quality of life besides making you live longer. So typical symptoms that patients may have with severe aortic stenosis include fatigue, shortness of breath, and some sort of chest pain. Sometimes they have difficult walking short distances without getting very short of breath or tired. And sometimes they get a little rapid heartbeat, swelling their legs, and don't want to do things that you want to do, and feeling dizzy or getting lightheaded and difficult sleeping. Obviously, some of the later ones are quite vague. So we obviously need to sort of talk to the patients in great detail. What are these symptoms? So usually sometimes you go sort of, many patients, because they're getting older, they say, well, I'm just getting old, therefore I'm tired. But obviously difficult for the patient himself or herself to know whether this is normal, worsening as part of aging, or this is actually worse. So that's why it's helpful, obviously, to talk to patients and their family to notice how quick is the change. So I think that's why it is sometimes difficult to talk to the patient alone, and talking to the family is very helpful because they can sense a greater decline than they would sort of normally expect. So the question is, how can you get diagnosed of aortic stenosis? If traditionally, if you go see a physician or doctor, that, the first thing they do, obviously, can check your blood pressure, check different things, and also hopefully they still use a stethoscope to listen to your heart sound. So usually by listening to your heart, you would detect a murmur if you have aortic stenosis, and a certain location of the murmur will point towards the aortic valve. So unfortunately, the stethoscope is pretty sort of vague in terms of how bad is the aortic stenosis. Sometimes aortic stenosis that's not severe can make a very loud murmur, and sometimes the aortic stenosis is severe to critical, and the murmur is relatively soft. The reason partly is that blood starts to not flow so well when you have very severe aortic stenosis, making the sound maybe a little weaker. So what is the best way to check whether the aortic stenosis, the murmur, is significant? And this is done by an ultrasound. So this is echocardiography. So essentially, it's like looking at babies, and this is using ultrasound to look at the heart as it beats. And you can use sound wave to produce an image of the heart. And then you can closely examine the aortic valve. What we can measure is the pressure difference between the left ventricle and the aorta. So as you can imagine, when there's no blockage in the valve, the blood just flows right through the valve, and there was no pressure difference on this one side of the aorta or one side of the left ventricle. However, if the aortic valve gets smaller and smaller in its opening, the heart left ventricle has to pump harder and harder, need a greater pressure to push the blood out. So therefore, if the pressure difference reaches 40 millimeters of mercury, that would become a critical number that we should consider changing the valve. So for example, if the blood pressure is 120 in the arm, the left ventricle may reach an average of 40 millimeters or more than the blood pressure. That's the time when we start thinking about changing the valve. So just to summarize, when we think about aortic stenosis, there are two big pieces of information that we need from the patient and from tests. One is that we want to know whether the patient has symptoms. And symptoms could be subtle, could be very obvious. And it's the job of the cardiologist and the patient's family to try to discuss whether there are symptoms. Second is how severe is the aortic stenosis, and that's best done by echocardiography. And what we're looking for simply is that the difference between two sides of the valve, the aorta on one side, left ventricle on the other side, and the difference reaches an average of 40 millimeters of mercury. The valve is now reaching to be a severe stage. So once we know that, unfortunately, medicine doesn't work too well. This is a very mechanical problem, meaning as if your kitchen sink is plugged. You can use Drano in that situation. Unfortunately, there's no such thing in medicine that can do that you can take into the blood without destroying the blood and everything else. So unfortunately, medicine may help to treat some of the milder symptoms, to sort of prolong the time that you have to wait for this valve surgery. So medicine, unfortunately, doesn't contribute a whole lot to the treatment in the long run. So before 2012 in the US, even though we start doing research of this particular procedure I'll explain later, in 2008, but the valve procedure through the leg is actually approved in 2012. But before that, the only way to do that is what we call surgical aortic valve replacement, TAVR. So surgical aortic valve replacement, called TAVR, is essentially, there are two approaches. Essentially, both of them have to go open up the chest wall and expose the heart. Traditionally, it's a long incision along the sternum, because then you can open up the sternum and look at the heart. Or nowadays, you can also have a very relatively smaller incision to access the heart in the top part of the chest. But nevertheless, whether it is the traditional longer incision or shorter incision, it is really the cosmetic part, right? The actual procedure requires a heart-lung machine. Why do you need a heart-lung machine? Because you have to stop the heart to do the valve. If the heart is not stopped, when you cut into the aorta, for example, it will be obviously bleeding everywhere. It's not possible. So you have to divert the blood into a heart-lung machine and then stop the heart. And then these aortic valve is completely removed and a new valve is sewn in. So it's sewn in like a seamstress. So it basically has a sewing ring and you sew it into the where the old valve was. Typically, the procedure may be a total of 3 to 4 hours, but you typically stay in the hospital for about a week, maybe 4 days in the intensive care, and a few more days in the ward before you go home. Obviously, depends on the patients, how well they are and how old they are. And then average after that, the recovery is about 30 days, meaning after you go home, you're still kind of weak, the chest is hurting, and you're a little anemic. There might be some arrhythmia or an extra beats in the heart. So typically take about 30 days for you to go back to feeling pretty normal. And the risk in general is about 3% of experienced stroke or death, because this is a big operation at 1 year. So this sounds like, at least before 2012, it's a great procedure. The risk is, younger healthy people is really less than 1%. But at least 40% of the patients who need a valve replacement do not get treatment. It's done by a lot of these studies before 2012. In green here is really a small percentage of the people that really need it get it. You say, why is the case? The part of the reason is that many of these patients may be a little older, and the risk may be a little higher, and the surgeons and the patient do not want to go through that. Or sometimes is that they might be underdiagnosed. There might be a murmur in an 80-something-year-old patient, and the doctor said, well, just a murmur, I've been there many years, and sort of ignore that. So therefore, even with good surgery, certainly quite undertreated, underdiagnosed. So in 2012, FDA approved this procedure called transcatheter aortic valve replacement. essentially is using a catheter, a tube that we can mount a valve on and change the valve through the leg. And this is really a sort of a groundbreaking procedure because it is for the first time we can change something that big in the heart without have to open up the chest. So this transcatheter aortic valve replacement, as you can see in this little cartoon here, is inserting the catheter and the valve through the femoral artery, which is the artery that supplies blood to the leg. And I'll show you a little bit more detail what this procedure looks like. Obviously, much less invasive with this aortic stenosis because it's catheter-based. So the heart is beating. The patient is sort of not really under general anesthesia, local anesthesia, and sedation. The heart is not stopped, so therefore it's no heart-lung machine, no ventilator. And we will insert the new valve within your old valve. The old valve is actually serve a very important purpose because the old valve is thickened and hardened. So when you put a new valve inside it and you open it up, the old valve is actually served as a scaffold to hold the new valve. It's like the corrugated wall on a rock, and you essentially put the valve there with a stainless steel cage. It prevents it from moving. Again, I'll show that a little later. And usually it's a one-night stay in the hospital. No recovery time. You pretty much the next day going home, you can do everything you want to do. And the procedure is about 1 hour. And the risk of the procedure compared to surgery is about 50% less. So majority of the time, patients have very little complication and essentially felt like, they can just go on and much better within a day or two. So let me see whether I can play this here. So essentially, if you look at a transcatheter aortic valve replacement, we access the leg through a small incision. And then through that incision, we introduce a little tube. This tube is approximately 5 to 6 millimeters in diameter. And then through that's what we call a sheath, we can introduce a little wire and a little tube. Essentially can let us go through the aorta. The aorta is much bigger than this cartoon and allow us to go backwards through the valve. And this is the diseased aortic valve. And we do a procedure sometimes, and nowadays a lot of times when we may not do it at all, is using a balloon to first stretch open the valve so that we can prepare the aortic valve to have the new valve inserted. But now the new valve is so good that we don't, and so small that we don't even need to do the balloon first. So this just illustrates to you the valve is crimped down, is pushed smaller on top of a balloon. So through the same little wire that we have thread through the valve, the stent valve now is put into the old valve. And then we make the heart beat a little faster so that the heart doesn't move. And then we open up the balloon and this valve is stretched back to its original shape and left alone in there. And then we take out everything. So this actual part of the procedure may be about 10 minutes to 15 minutes. And the rest is preparing the leg to sort of insert the valve. So this is the new valve, and valve leaflets are inside this cage. So that is sort of now allows the blood essentially go through unimpeded. The old valve is staying outside, holding the new valve. So let me illustrate with a real patient. So this is a patient we did a couple of weeks ago. Sorry. So this is an 88-year-old Asian woman, high blood pressure, high cholesterol, diabetes, have GI bleeding, because this sometimes can happen in patients with aortic stenosis. They have a concurrent problem in the gut that create little blood vessels and have more tendency to bleed, has shortness of breath and leg swelling. So she was discovered to have aortic stenosis with a pressure gradient between the valve of 50. Remember, we said 40 or above is critical or severe. So she has severe aortic stenosis. The heart function is still normal. The ejection fraction, which is a measurement of how well the heart pumps, is within normal range of 60 to about 70. So, and we also check whether the leg arteries are big enough to introduce this valve. So the two pictures here shows you the this is real person in a CAT scan. You can see this is the top down view of the valve. So the valve is this 3 pieces there, and the white pieces are the calcium that's been built up in the valve. And the orange part, these are the coronary arteries that supply blood to the heart. So this is a way that we can measure the size of the valve. What size do we need? And also to allow us to measure some more details. Are there any risk of these calcium breaking off? Are these calcium could crack? So many things that we do technically. This is also a CAT scan of the leg artery. And you can see that there's some tortuosity, some turning. But if it's very, very turned and hardened, sometimes the catheter could have a hard time going through this aorta. So that we also do the CAT scan to determine how's the path going from the leg to the heart. We don't want it to be lumbar street because then it will be very hard for us to steer the valve into the heart. So let me show you, this is actual patient. This patient, again, now what we're doing is under X-ray, what we call fluoroscopy, we can now sort of look at how we place the valve. So this is a patient. This is the spine. There's a heart there. You can see that something is moving, is beating. But obviously the heart is transparent to X-ray, meaning that X-ray cannot see the heart unless we give a dye. And if you give dye, then that part of the heart that has the dye filling it will become black because the X-ray won't go through it. So this is a little catheter that we place in the top part of the valve. So the valve is sitting right where my arrow is. And then we give some dye to locate the valve and also measure the size a bit, as well as measure the location that we want to put the valve in. So this shows up in black here as the coronary artery. So this particular procedure allows us to really locate the valve, determine where it should be, the valve be placed. On the right panel here, now you can see at the actual valve. So this little catheter is still there to tell us where the position should be. And this is the valve mounted inside a cage called a stent. And this is the catheter that we use to push the valve into it. So this is approximately 5 to 6 millimeters. And so we try to use a dye to determine where's a good spot to put this valve. And the little dot is the middle of the valve. So we want to put it in a certain location. So then we make the heart beats a little faster. So you can see the heart beat faster than before using a special pacemaker. And then we'll play it again. So you can see we open up a balloon. The balloon stretch open the valve, which is inside. And then we deflate the balloon and the valve will work right away. So the actual deployment of the valve may take 10 seconds to 15 seconds. So once we open it up, we deflate the balloon and take everything out. So the valve will stay behind. As you can see in this picture, the valve is left behind just like the cartoon I showed you. The valve, you cannot see itself because it is, again, tissue. Therefore, you cannot see the valve, but you can see that the blood is going forward, dye is being washed out. And we measure the pressure difference between the two sides. Remember, when it was abnormal, the pressure difference is about 50 millimeters in this particular patient. But now when we finish, we put a new valve in, there's no pressure difference as like a normal valve because there should be no pressure difference on the left ventricle on this side to the aorta on this side. We also give dye on both the valve to make sure there's no leakage because in the older generation, sometimes there's sort of cracks outside the valve. Between the new valve and the old valve, there's little crevices. And those crevices can allow blood to leak back into the left ventricle. So these new valves have actually a skirt that's made of tissue that will actually attract blood and then clot a little bit and prevents blood from leaking backwards. So if you see blood leaking backwards, you'll see dye floating backwards into the left ventricle. But here, there's none. So this is a very successful procedure for this 88-year-old woman and basically stay overnight. And then she went home the next day and pretty much returned back to normal activity that, the next day, afternoon or evening. We finally also do a procedure, a check, make sure that the femoral arteries are not injured because we put a pretty big catheter in there. You can see there's a slight narrowing on this side. This is where we make the cut and introduce the catheter. Usually that will just heal up fine once the suture is gone. So what does this procedure treatment-wise do to the patient? We can say, well, everybody needs it, but we need to measure it. We need to do clinical studies for it. So on the left panel here, this is the very early study, essentially comparing standard therapy, meaning in patients that are pretty high risk for aortic surgery. At that time, there's really no operation, no option for them, just taking some medicine and just wait. So the early study, we sort of randomized. We select half the patient randomly and do the TAVR, and the other ones just continue medical therapy. Essentially, would decrease the incidence of death from any cause by 50%. This is over 2 years. So these are very sick patients already because they are felt by the surgeon to be inoperable. But even in these patients, when we put the valve in, they live much longer, much better quality of life, as shown on the right panel here. This is a measurement of pre and post, how well people feel. And if you look at the sort of what we call the KCCQ score, essentially patient pre-TAVR have a score about 45, and it increased quickly within 30 days to 81, almost doubling sort of the measurement of quality of life. And then, at 1 year, it increased even further. So quickly, you can see the quality of life of these patients improve significantly as well. So you may think that, by now, after maybe a decade of the transcatheter valve technology, most people that have aortic stenosis will get treatment. But you can see that when it was first released, only 4% of the patients that should have aortic replacement got TAVR. Obviously, over time, it increased to about 20% in 2016. So over time, as doctors are trained, as patients understand this procedure, as the technology get better and better valve, smaller and smaller catheter, more and more people are basically getting treatment with the TAVR procedure. The surgical numbers have diminished, and actually in the United States now, many more patients are treated by this TAVR procedure than by surgery. So if you don't need any other surgery, bypass operation, other valve problem, the standard treatment now for age 65 and above in the US is the TAVR procedure. But interestingly, as just like many things, there's issue of race and ethnicity in terms of whether you get to have the procedure done. For example, in average, the Black patients are 24% less likely to receive a TAVR, maybe because of access, maybe because of issue of understanding the procedure. But you can see here whether it's surgical or TAVR is still significantly less than the white population. And if you look at overall in terms of looking at it's hard to see underneath here. 1 second. That if you compare sort of white, Black, Asian, and other, majority of the patients getting TAVR are still white. And you can see Asian represents a relatively small population, similarly Hispanic and non-Hispanic. So there's really obviously an issue of access, race, and understanding the procedure. So I think that's really still a big barrier for us in our Asian community to really explain this procedure better and help people understand that this is actually a very relatively simple procedure. There's access for patients easily. On average age is 80 plus, and our oldest patient that we've done is 102. As usual, again, women are generally treated less often with TAVR procedure or surgical procedure, and usually later than men. Again, symptoms sometimes could be an issue, as they can sometimes present with what we call low flow, low gradient aortic stenosis. The heart is weakened, and the valve never generate enough. The heart never generate enough pressure to reach that number 40, for example. But nevertheless, I think we're now aware of these conditions and pay more attention when women come in for this type of procedure. So the challenge that we want to sort of get you all aware of is really this patient care pathway that we don't want to lead to unnecessary delays in treatment. So patients need to be aware of this condition, recognize if they've been told that they have a heart murmur and they have noticed some of the decreased activity that they are seeing, whether it is some shortness of breath or fatigue, that they should contact their doctors and have it evaluated whether they have aortic stenosis and how severe. And obviously detect and diagnosis is stress on the physician. So expert auscultation, listening to the heart, as well as the echocardiography, interpretation, measuring those gradient, the pressure difference is very important. And they have to be done well because it's very easy to miss some of these gradient and you can get a low number while the real number is actually quite high. Then depends on where you are and how well the center has been doing this procedure. If it's not locally available or locally available but relatively new, then I think for patients, they should consider going to other more experienced center to be evaluated and see whether they're a candidate. So again, this procedure is now really worldwide available. Certainly more than 500,000 now. A patient worldwide has been treated with this particular catheter, but there's other brands that are also being used to do so. So probably more than now close to 750,000 or so, and available pretty much most countries. And now the approval, as I said, is first approved in 2011, 2012 in the US. So I showed you one valve. This is one type of valve. We in the US use two major types. This is called the Edwards sapien valve. And essentially, I show you there's a cage of metal. It's like a stent that can be stretched open, the valve sitting inside. And the most latest iteration called a Sapien 3 Ultra, I have this little cuff outside to prevent leakage through the crevices. Available in 4 sizes. So we have to really be careful to picking the right size, because that will help us really prevent leakage and making sure the valve works well. There's another system that is a self-expanding system. This is a valve that basically opens by itself. And once you unsheath the catheter, so it sits inside the aortic valve and pushes out, and the valve is inside. So this is called the Evolute system by Medtronic. So who is eligible? You may ask, am I too old? Am I too weak? Am I too, frail? So obviously, expert evaluation by a heart team is the most important. But as I said before, age is not the limit. There are many patients that are in the 90s that are really still have good quality of life, or had good quality of life, and with aortic stenosis has decreased. So I think this is important, and essentially getting a good evaluation is very the first step. And again, usually in the old days, the first when this is approved is really for patients that are not eligible for surgery. Then it goes to patients that are high risk. They are traditionally high risk for open procedure. Then it moved to intermediate risk, and now low risk. So essentially, anybody that aortic stenosis that is severe enough to warrant a valve change, as long as they're over age 65, they're eligible. Their patient, obviously under 65, can also be treated with TAVR. The reason that we sort of have cut off, or the FDA has a cut off 65, is that the younger you get, any of these tissue valves, including surgical tissue valve, don't have a lifespan about 10 to 15 years. That means that, if you are younger than 65, very likely that you might need another valve procedure. So they want us to be careful and think through it. How do we have a lifetime strategy for patients with aortic stenosis, and not just looking at one valve, maybe multiple valves? How do we do multiple valves? So again, this is that's my talk, and you can find more information in whether it's American Heart Association. This is the company, there's a website called Mended Heart, American College of Cardiology, talk about heart valve disease, and obviously many other sites as well in terms of looking at heart valves. And certainly, happy to answer any questions.
Thank you very much, Dr. Yeung. It was such an excellent talk. It was truly wonderful. As a general cardiologist, I really find this technology really revolutionary. I remember back in the days when I first came out of fellowship, 15, 16, 17 years ago, it's often a very difficult discussion when you have someone, who have severe symptomatic aortic stenosis, and they're 90, 91, 92, and or even, in the upper 80s, and no one would touch them. And it's so hard to talk to these patients and talk to their family about there's very little we can do for these patients. And this procedure really revolutionized the entire landscape of aortic stenosis. So thank you again for the talk tonight. Thank you for the audience. We have a very engaging audience tonight. There's a lot of questions. So our first question tonight is this one. Once the TAVR is performed, what is the expected life expectancy or longevity of the device operation?
Right. So the valve itself is made of either cow or pig pericardium. So it's a lining of the heart in the animal, and it's sort of cut out as a piece of tissue. So even though our technology nowadays are so good, but we still cannot manufacture tissue that is comparable to, from sort of a biological source. So that tissue generally is cleaned and then treated with preservative to sort of really make sure that there's no infection, there's nothing else in there. And then the valve is cut into little valve leaflets and then sewn into this cage. So whether it's surgical or catheter valve, the average age is about 10 to 15 years. Then that valve, unfortunately, will harden again and may not open again. But again, some patients have the valve for 20 years and have no issue. So the average age, I would say, between 10 to 15 years. And the younger you are, the more likely the valve will actually calcify, because young person's metabolism is a little different and they tend to sort of calcify things. So the younger patients, I think, when they're less than 65, there's a discussion of whether they should get a mechanical valve, mechanical surgical valve, because we cannot make a mechanical valve go through a catheter because it's made of metal or carbon and fix this. So they have to be open heart, put it in. The downside about that, the good side about it is lasts for a long time. The downside is you have to take a medicine called Coumadin to thin your blood, because these metal tissue surface is very attractive for blood to form clots. So therefore, you have to take a medicine called Coumadin to thin your blood, and you measure your what we call INR, so an index of how thin your blood is continuously. And also, as a woman, if you are childbearing age, you can't really take Coumadin that well, and that's obviously having a child is very complicated when you're on Coumadin. So tendency now in worldwide is less and less patients are getting the mechanical valve, even when they are younger. The idea is that they might get a reoperation or they will get a TAVR valve inside the surgical valve as they get older. So imagine you're 60 years old, you have a surgical valve placed because they put in surgical tissue valve. It may last you 15 years. And so now you are 75, and then the valve deteriorated. At 75, we can put a catheter valve inside the surgical valve, so-called valve-in-valve. So from 75, you buy you another 15 years. So now you're talking about, close to 90 years old. So maybe at 60 years old, you can have surgical valve followed by a catheter valve.
Mm-hmm. Thank you very much. Yeah. So the next question is very similar to what you just described. So let's just go over this one. My 14-year-old son was born with the tetralogy of Fallot and may soon need a TAVR. Can you talk about long-term outcomes? And that's a tough one, 14 years old. What do you think about that one?
Yeah. So we have done sort of catheter valve, whether it is in a pulmonic position, which is, a different valve. And for tetralogy Fallot, that typically could be the valve that needs to be changed. And there's a special valve made for that called the melody valve, similar concept, but used in a pulmonic position. Obviously, much less common because congenital heart disease patients are still relatively small minority, but they can be put in that way, similar concept, but in the pulmonic position. But obviously, the issue is whether they will last long and how the pulmonic position, fortunately, tends to last longer because there's less pressure damaging the valve because the pulmonic pressure is much lower. So tendency is that it may last longer.
Okay, yeah. And this one's similar too. Is there a age cutoff that TAVR is no longer appropriate or not recommended?
Yeah, we talked a little bit about the younger age. Certainly we have the average age of many of these TAVR procedure when it's age 80 plus. And therefore we have done patients that are 100 years old plus, but they have to be pretty healthy and pretty strong. So there's really no physical limits in terms of the age. It's really the quality of life the patient has. So obviously there are patients that are much younger, but they are now bedbound. They have other conditions that make them really don't do very much. Then a TAVR procedure is probably not appropriate because it's not going to make them any better if they have other conditions that limit their physical activity and their cognitive function, for example.
Wonderful, thank you. Yeah. So one of the audience have this example. It says if you already have 2 surgical aortic valve replacement procedures and have a cardiomyopathy, how does that change the risk and the success rate for the outcome for the TAVR procedure?
Yeah, so I presume obviously the devil is in the detail here. So if you have the heart muscle is weakened for a long time already, and it's a primary problem, that obviously is a separate issue. But if the heart muscle is weakened because the surgical valve has been failing, and that we have evidence that the heart muscle can recover, we can change put a new valve into the surgical valve. We can put in what we call valve-in-valve, put a TAVR valve inside a surgical valve. get rid of whether it's a leakage, whether it is not opening, the heart muscle may get stronger and improve on it. So, but unfortunately, much more detail need to be determined, whether there's permanent damage to the heart muscle from other reasons, or is it really related to the valve? The more is it related to the valve, more likely that the heart muscle will improve.
Yeah. And isn't the diagnosis for severe aortic stenosis in cardiomyopathy sometimes a challenge too? Can you comment on that too?
Yeah. So as I explained that, the number 40 is when there's a normal left ventricle pumping the blood and generate pressure difference between the two sides. So imagine the heart is weakened, it's not pumping so much blood each beat. Therefore, by just sort of equation or just the nature of blood flow, is that if it squeezed much weaker, the gradient, the number 40 will be lower because there's not much blood flow across the valve. You can take it to an extreme. A person is, obviously in dire strait, pumping very little blood, 5 cc's of blood. There'll be no pressure difference on either side because both sides will be low and therefore no more gradient. So the criteria of 40 is assuming the left ventricle is normal. So if the left ventricle is not normal, then we have to either give medicine to strengthen the heart, to test it out to see whether there's reserve in the left ventricle to pump harder, or we can also do some other sort of CAT scan, other things to look at the valve. Is it really disease, or is it the valve looks okay but the heart muscle is not pumping? So more tests to do that.
Thank you very much. Yeah. And we have some questions about the Asian population. So someone is interested to know, among the 2,600 procedures of TAVRs that were done at Stanford, approximately how many of these Asian American patients, and how do you think those populations taking on the concept?
Right. So I think it's the general numbers, I would say Stanford about 20%, which is quite high compared to many of our sister institutions across the country, because we have a relatively large Asian population. And I define that as obviously Asian, not just Chinese, not just Japanese, but pretty much from South Asian, Filipino, everybody included. Generally, the size is a little smaller, but the arteries surprisingly are not smaller. So, most of the time we can fit the catheter valve in, and we can select valve in big enough or small enough to treat these patients. So in general, they actually tolerate the procedures very well, as I shown in my example, the 88-year-old Asian patient. So I think what is missing a lot of times is that maybe the Asian patient never heard about this procedure or scared of any procedures that may be related to open heart or heart operation. So that's why I think a talk like this, hopefully, whether it's today or whether it's on YouTube, will be helpful to reassure people that this is a very safe procedure across all ethnicity and pretty much across all age group. Obviously, in terms of the risk is relatively acceptable.
Very good. Yeah. And someone asked the question of just an interesting one. I never thought of that. With TAVR, what actually holds the valve in place?
So if you imagine the original or the old valve that is diseased, has thickened, has calcified. So if you look inside the valve, if you have a normal valve, it's very smooth tissue, But if you look at the diseased valve, you cut it out, it's really bumpy. And a lot of bumps are little nodules of calcium. And the nodules of calcium are irregular, and some place could be pretty sharp. So imagine if you're putting the new valve in, you push this valve out, that surface that is irregular is actually locking the new valve in a circumference, right? So 3 leaflets are pushed up, new valve sit inside, and the calcium, all that is holding it. Also, the valve is sized very carefully to match the size of what we call the annulus, where the valve is. Too small, it will fly, right? No matter how much valve tissue is there to hold it. Too small, there's not enough force to hold it. Too big, the problem is that you can crack where the valve sits and cause a perforation or opening of that area. So that's why the CAT scan is very important for us to do it before the procedure to carefully determine the size of the annulus.
All right. Yeah. Wonderful. Yeah. And let's look at this question. There was a question about mitral valve treatment by catheter. So would you comment on the clinical trial going on to replace or repair the mitral valve by catheter? Is there such a thing? Or is it
Yeah,
only for
so
the aortic valve?
TMVR is a new research area. One area that we are doing, and fair amount of centers are doing already, is that if you have a surgical mitral valve done before, it's pretty easy for us to put a TAVR valve into the surgical mitral valve. It's a valve in because you have a scaffold of the mitral valve holding that new valve. The native mitral valve is a complex structure. The aortic valve is pretty simple, a ring, and then you have 3 leaflets. The mitral valve is like a saddle, has a 3-dimensional nature to it, and there's a lot of soft tissue, harder tissue. So very difficult to put a valve in that is circular into a saddle. So the newer technology to look at this is sort of it's like a whole apron of a valve to put in the mitral position. So that's being sort of investigated. The system is still too big to go through the groin, and they're miniaturizing it to be small enough to go through the leg. Right now, some of the research finishing up is go through the tip of the heart. So they have opened up the side of the chest, locate where the heart is, and put a hole in it and put the valve in. But that obviously had risk because it's general anesthesia that has to be making a hole in the heart that can bleed in older patients and so forth. So transcatheter mitral valve replacement is coming, but it's harder than aortic valve and being studied pretty hard right now.
Got it. Okay. And there are also this apical approach for TAVR too, right? And so is that not common anymore? How frequent that
it
thing
was
is?
the original when we first developed TAVR, because the catheter is so big, a lot of the femoral arteries will not take that valve, will not take the catheter. So we have to find a different way to put in, but much more risk, bleeding. The heart suture doesn't take. Remember, these are older patients. The tissue could be very weak, very soft, and they actually don't hold sutures very well. So pretty much transapical TAVR is gone. Just too much risk and too many complications.
Got it. Yeah, it's good news for patients. So pretty much all of these patients can be done through the leg artery. So that's good news for everyone.
Yes.
Yeah. All right. So I think we cover most of these questions. If you can just let me just take a last peek on the webinar chat. So is TAVR valve a pure mechanical device? Would you take on that one? Yeah.
Yeah. So the TAVR valve is really, the cage is metal, but inside is just the animal tissue valve. So essentially it's similar to a surgical, what we call bioprosthesis, is a biological tissue valve. Mechanical valve typically is used to describe the valve leaflets are made of metal or carbon fiber material, for example. So that will be called mechanical valve. Mechanical valve, as I said before, needs much higher level of blood thinning, because blood tends to form clot on these tissues.
Okay. And during TAVR, is there a chance the procedure can break loose the calcified deposits on the aortic valve and embolize somewhere, in the brain or something?
So this was one of the fear in the original concept. It's like, you're breaking apart this valve and the pieces come off and shower to the head and everywhere and causes big strokes and so forth. It turns out when we did the procedure in the beginning, the incidence are pretty small, 1 to 2%. But despite that, people would say, well, can we improve it? So there's actually a device invented. It's called, it's a filter system that put in the neck arteries. It's called Sentinel, a brand name. Essentially a little fishnet that has little holes that let blood goes through, but doesn't allow debris to go through. So the concept sounds great, but in clinical trials, it doesn't seem to make a big difference. They caught something, but most of the time, when you have good circulation in the brain can tolerate some of the little tissue and nothing happens. So it's still that we think you don't really need the Sentinel cerebral protection device. You can do it without it. But in some patients, we choose to do so. It's still an area of research.
Got it. Okay. And then, wow, there's still a lot of questions coming in, so I have to be a little bit more selective for the last few minutes. Can a smartwatch detect aortic stenosis?
Well, hopefully a smartwatch is pretty smart, but not smart enough yet to be able to detect aortic stenosis.
Maybe in the
Potentially, I can
future,
see
right?
that a smartwatch in some way can detect a heart murmur, a sound of that such nature, but it's going to be pretty hard for it to detect the severity of the aortic stenosis. But yeah.
Right. Okay. There's a lot of questions. I think you probably answered that already. There's a lot of questions regarding like, what is the oldest age, and I think you already answered that question, right? Yeah. How old a patient can be for considered TAVR. Yeah. So as long as the patient is healthy enough, right?
Yeah.
Yeah. Okay.
I see
How
a
about
question
someone
here.
with
Say heart working too hard. I was thinking about that when causing this disease. It's not heart working too hard. It's just heart working normally. And the valve is somewhat a little bit maybe asymmetrical, other reasons or risk factors. So some people say, well, argue that you only have a certain number of heartbeats per life, meaning whatever years you have. So therefore you want to save it. That's people who doesn't want to exercise. I heard many excuses that, I don't want to exercise because I don't want to waste my heartbeats. But there's really no such thing as the heart is an organ that needs to be exercised. So I don't think the heartbeats is an issue. So the heart is working too hard, not because it is working too hard. It's working too hard because of the aortic stenosis. And therefore, it has no choice. It's not like it can choose to not work hard, because if it doesn't work hard in an aortic stenosis situation, then the heart failed. So the heart has no choice but to pump against this hole, so a smaller hole, to keep the person alive.
Okay. I have one last question. This one's for myself. So, is there any hope in the future that this technology can be extended to patients with severe aortic regurgitation? And if not, then what would be the difficulty?
Yeah. So actually, this technology, TAVR, originally was actually invented with the idea maybe it can fix the aortic regurgitation. So that's why it's the second valve that has a longer cage to sort of locked into the bigger part of the aorta. Because they was also thinking about, that's possible to put in aortic stenosis, valve to calcify, the valve won't work. So that was the original concept. So if you have pure aortic regurgitation, there are some newer valves that probably would do better than what we have, the two of them we have now. But if you have a combination of aortic stenosis, meaning the valve is thickened and you are leaking as well, then TAVR is fine. The reasons that there are some aortic regurgitation patients, typically younger, the valve is completely pristine. It just won't close. There's a hole in it. Then putting a valve in has nothing to hold it, right? There's no calcium nodule, no thickening, and the valve, every heartbeat will leave.
Yeah, got it. Wonderful. Yeah. Well, Dr. Allen, yeah, this is a wonderful talk and wonderful discussion after the talk. So I think a lot of us have learned so many new things tonight. I want to thank you for the time tonight and your presentation, and thank you for doing this magical procedure for many of the patients we have at Stanford. Yeah.
Thank you, Justin, and thank you for the team for organizing this, and thank you for the audience being so actively asking questions. Thank you.
All right. Thank you for attending. Good night.